Well, in ENT surgery, we use the LMA flexible for tonsillectomies and adenotomies, especially in pediatric patients. This is due to the fact because the ENT surgeons have to place a tonsillary gag into the patient's mouth, and so we cover it underneath the tonsillary gag, and due to the fact that they need space to be able to work on the patient, this is the indication for the flexible. Because a Supreme or even a ProSeal would take too much space, and they were unable to have enough space to operate then. The thing is, first of all, the LMA does not interfere with the operating field of the surgeons at all. The only problem that may occur is when they open the tonsillary gag to widen the mouth, that they kind of obstruct the LMA and the tube of the LMA. And this is the thing what you have to take care. So when he opens the tonsillary gag to widen the mouth, that you still have the possibility to ventilate the patient, and there is no obstruction of the tube of the LMA. The second thing that may occur is at the moment when they are inserting the tonsillary gag into the mouth, that they sometimes push the tube as well a bit in, and then they get a kind of a kinking and a siphon style. So they are obstructing their field of operation. In that sense, they have to reopen the tonsillary gag, and you pull the LMA a little bit out to straighten the tube again, and that's it. So there is actually only this kind of problems in terms of insertion and interfering with the tonsillary gag. It's a perfect tool. There is no other tool that provides this, and due to the flexible tube, it's just perfect. And we are using this kind of technique for more than 13 years now in my department. And we do know also from studies that the incidence in these pediatric patients of laryngospasm, bronchospasm, even postoperative bleeding is dramatically reduced, because the stress in the awakening phase is limited, and it's much better in the wake-up period for the pediatric patients, rather than having a tube which is causing the just mentioned problems like laryngospasms and bronchospasms. The only thing when I refrain from inserting an LMA is if we have a recurrent bleeding after tonsillectomy. This is an emergency case. This is a case which is a non-fasting patient, and it's a clear contraindication for the use of LMA. You have to have a good relation to your surgeon, and initially they are always a bit curious about new techniques, yeah? But once they experience the fast emergence of anesthesia with an LMA and the shorter changing times, they just love it. And my ENT surgeons, they wouldn't like us to do a tube into these kind of to use a tube for these kind of patients anymore, because the quality of recovery is outstanding, and as I already mentioned, even the reoccurrence of bleeding postoperatively is much lower, because there is less stress in the emergence of anesthesia.